I'm David Lubar, Chair of the GMC. It's been 9 months since the COVID pandemic changed our lives and how we live. Now with new vaccines being approved and being on the cusp of distribution, we can start thinking about next steps and what the new normal is. Helping us with that, today we welcome an expert lineup to share local and national perspectives on COVID-19 vaccine updates. We have 5 guest speakers today: Dr. John Raymond, Mayor Tom Barrett, Dr. Norman Baylor, Dr. Stephanie Schauer, and Dr. Tito Izard, who will share insight on the current COVID-19 caseload and hospital capacity, the emergency use authorization, the safety and efficacy of vaccines, and distribution plans. Following our speakers, we will have time for Q&A. So please submit your questions in the Q&A box, not the chat box. To begin today's program, please welcome Julia Taylor, who will share updates on GMC initiatives. Julia?
Thank you, David, and good afternoon. It's great to be here virtually with all of you today. And what a perfect day to talk about the COVID vaccine as it shipped this morning in the US for the first time. And as we adjusted in this year of the pandemic, the GMC made many changes in how we deliver our programs and how we communicate with our members. There were opportunities to deliver information more quickly, and certainly it was easier to connect with national experts and speakers like we have at our membership meeting today. This pandemic showed starkly the disparities and the lack of resources in many parts of our community. A great deal of our work this year is finding ways to bridge these issues with your help. As we will hear today, 2021 will bring some relief, and for some, a closer return to normalcy. For many, though, the losses of this year have been immense, and our work will continue to change and address these issues of equity. So here's an update on our programs. The Commons Virtual Career Accelerator completed its 5th week in November. Its 5-week session in November. The program was designed for juniors and seniors in high school, currently enrolled college students, and recent college grads who are un- or underemployed. The 40 participants received 20 hours of career exploration, professional development, mentorship, networking, and team-based innovation projects. They also, most importantly, gained exclusive access to local employers, mentoring professionals, and additional educational opportunities. The Commons will run a similar career accelerator again in 2021. And we're also halfway through the inaugural Forward 48 class, which is creating a robust and diverse civic leadership succession strategy through experiential learning, professional development, and exclusive networking opportunities. The Virtual Career Accelerator and Forward 48 is providing access and opportunity for emerging leaders of color to ensure a diverse and inclusive future Milwaukee. The Milwaukee Area College Internship Consortium, known as MASIC, just bestowed on the Commons the Pivot Award for so quickly providing support to 140 students with stipends and a virtual internship this summer. It's the first time the award has been given. Scale Up Milwaukee has been busy with another Spark Accelerator designed to infuse growth and spread inclusive economic prosperity. The Spark Accelerator works with entrepreneurs of color and women-owned businesses between 100,000 and 1 million to grow at a rapid yet sustainable rate. These businesses are a key factor in commercial corridor redevelopment. 16 of the 28 participants on the current cohort and 67% of all the graduated businesses are owned by entrepreneurs of color. The current cohort focused on typical curriculum of sales and marketing, organizational development, and finance, but this time also addressed the digital divide that many businesses face. Through a partnership with Square, a merchant and digital services platform, Spark and Scale Up member companies have begun to create a digital infrastructure to help them operate, survive, and grow during the pandemic. On December 16th, Scale Up is hosting its annual meeting to celebrate its most recent Spark cohort with keynote speaker Adonica Randell. Adonica is president and chief problem solver of Abagsit, an 18-year-old certified MBE, WEE technology solutions company. We invite you to attend. Just RSVP to Elmer or Mallory at the GMC. Recently, the city of Milwaukee was presented with an Excellence in Planning Award from the Wisconsin chapter of the American Planning Association. The award specifically recognized the creation of the Milwaukee United Anti-Displacement Fund in 2019, which combined the work of both the city and the private sector to help prevent gentrification due to rapidly rising property values and taxes in historically disinvested neighborhoods. Milwaukee United partners include the GMC, the City of Milwaukee, the Greater Milwaukee Foundation, Urban League, and LISC. Last year, we were able to support 111 homeowners, with 75% reporting to be people of color. The 2020 application is now open, and we've already approved over 70 homeowners in Halyard Park, Harambe, Brewers Hill, and the Walkers Point neighborhoods. Milwaukee United also continues to partner with LISC on Brew City Match, which is hosting its 4th round in the spring. We are currently accepting applications for the 8th Annual Mary Ellen Stanek Award for Diversity in Corporate Governance. This prestigious award is given to an individual or entity that's exhibiting leadership, influence, and impact, resulting in increased diversity on corporate boards in our region. The award was named after Mary Ellen Stanek, the Managing Director and Chief Investment Officer of Baird. And this award also honors her tireless commitment to diversity in the corporate structure. 2020 winners included Linda Gorens-Levy and the Wisconsin Energy Group. Please submit your nominee's name to Elmer or Heather at the GMC by January 15th. Nominees will be reviewed along with Milwaukee Women, Inc., and the awardee will be announced at the Greater Milwaukee Committee membership meeting on February 8th. That's our program update, and I would now like to introduce Dr. John Raymond, President and CEO of the Medical College of Wisconsin, to share his updated COVID dashboard. Dr. Raymond and the staff at the Medical College work tirelessly to share accurate and timely COVID updates with our membership and our region, and we are very thankful for your presence at these meetings. Welcome, Dr. Raymond.
Thanks, Julia, and good afternoon, everyone. If we could go 2 slides down, please. Thank you. Just want to give you an update on the COVID-19 situation. These are screenshots from Worldometers, a really good website, from yesterday afternoon. And at that time, we had almost 73 million coronavirus cases in the world, nearly 17 million in the US, and over 400,000 in Wisconsin. 1.6 million deaths in the world, 300,000 in the US, and we just passed 4,000 in Wisconsin on Saturday. You'll note the death rate in the light purple percentage numbers under deaths, a little bit different. In the world, there's been a 2.2% case fatality rate, 1.8% case fatality rate in the US, and by the way, that is dropping, and a 0.9% case fatality rate in Wisconsin. I believe because we didn't have a significant first surge, and we've never overwhelmed the health systems, although we came very close a month ago, probably accounts in large part for our better death rate here in Wisconsin. And then just to show you at the bottom, most people have recovered, 51 million in the world, almost 10 million in the US, and nearly 400,000 in Wisconsin. And I do want to make sure everyone understands the definition of recovered is either resolution of most of the major symptoms of COVID-19 or 30 days since diagnosis, either by symptoms or by test. There are many people, maybe as much as 1/3 of people who've had COVID-19 that have persistent symptoms, and they're referred to as long haulers or to be suffering from long COVID. So just because you're recovered doesn't mean that you're back to your pre-infection state of health. And I think that's a very important point for all of us to remember. Next slide, please. Now I want to answer a question that people have been asking me. And the question is Wisconsin's COVID-19 pandemic decelerating? And I'll just start by saying the answer is yes. There's much evidence suggesting that it's decelerating, and I'll go through that on the next few slides, and then I'll speculate a little bit about why that might be. But Wisconsin's COVID-19 pandemic did begin to show early signs of either plateauing or decelerating about 4 weeks ago. And we can see that compared to the rest of the country, we are doing better. So for example, the New York Times has a COVID-19 metro tracker. And 5 weeks ago, we had 11 of the top 20 metro areas in terms of burden of disease. Right now, we only have one, Beaver Dam, and that has been dropping in the rankings consistently over the last few weeks. And more than 24 different Wisconsin metro areas were in the top 20 and have fallen out over the last month. And in another bit of good news, Wisconsin has no metro areas that are on the top 20 list now where cases are increasing the fastest. And that's down from 8 out of the top 25 weeks ago. And then finally, I'm sure everyone's aware that the daily case counts of new COVID-19 diagnoses are dropping as well. Next slide, please. These are screenshots captured from the Wisconsin DHS website showing Wisconsin's 72 counties with the 2-week average of COVID-19 burden. Starting at the left, the first 2 weeks in November showed that 71 out of our 72 counties had critically high levels of COVID-19, with the one remaining county having very high levels. Moving over to the second frame from the left, you can see that the next week, the average was down a little bit. We had 6 counties that were very high, but not critically high. Then moving to the third panel, you can see an increasing number of counties that have a very high, but not critically high burden. And then the latest data between November 25th and December 8th showed that there was a very significant deceleration, most of the counties moving from critically high to very high. But I want to point out that even though we're moving in the right direction, the current burden that we have in all of our counties is very high. And it's higher than it was even at the peaks that we saw in March, April, and May. And next slide, please. More evidence of deceleration here. Our COVID-19 hospitalizations have dropped steadily from peaks about 4 weeks ago. ICU census has also declined now for the state. It's down below 84%. It peaked at nearly 95% just a few weeks ago. But I want to point out that this still exceeds the peak of the spring surge. Total hospitalizations and ICU occupancy, including both COVID and non-COVID patients, also has decreased, but is still higher than normal at 82.5%. And the reproductive number, which is a measure of contagiousness of the disease, has been below or at 1 for the last 4 weeks. Now, ideally, we want that number to be significantly below 1 for an extended period of time to show that we're truly getting the pandemic under control. Doubling times, in other words, the time that it would take to double the number of cases of COVID-19 in Wisconsin, have stabilized, but they are worse than they were at the end of September. And the 7-day average positivity rates have started to drop, which is good, but they're still very high at 27.8% of the cases in Wisconsin and 10.9% of tests administered. Now, to put this into perspective, New York has triggers for increasing the stringency of their interventions for COVID-19 at 1%, 2%, 3%, and 5%. So we have a long way to go. It is possible that many people simply are choosing not to be tested because there's a good understanding of what the symptoms of COVID-19 are, and people may not want to wait in line to get their test, or they may be concerned that they might not have their test turned around within a couple of days. And that may be one of the reasons why this positivity rate is high. But even so, it still means that there is a lot of COVID-19 burden in our communities. And again, the 7-day death rates have started to drop, peaked at 59 last week, but they're still very high, averaging nearly 50 deaths per day. Next slide, please. I want to start, this is a complicated slide. I'll start at the top left. You can see that we've tested 2.7 million people in Wisconsin for COVID-19, and 436,776 of those were positive. The remainder were negative. If you continue to move to the right, you'll see as of yesterday, there were only 2,757 new cases reported in Wisconsin, continuing to trend downward, and 604 in Milwaukee, Again, you can see on the upper right that the case positivity rates remain high. I'd like to go to the bottom left and show you the trend line for the number of cases reported each day in Wisconsin from the beginning of the pandemic in March on the left through yesterday in December on the right. And if you follow the red line, which is the average of the plot, you can see that about 3 to 4 weeks ago, we peaked and then started to trail off in the number of new cases diagnosed each day in Wisconsin. Compare that on the right to US cases reported by the New York Times. And these are both screenshots. The one on the right is from the New York Times yesterday. And you can see that the United States still is increasing in the number of daily cases reported, although it appears that hopefully we may be plateauing in the near future. So Wisconsin is about 3 to 4 weeks ahead of the US in terms of trends. Next slide, please. Starting at the top left again, 88.5% of Wisconsin cases have recovered, 10.5% are currently active, and 0.9% have died. Moving to the middle frame on the left, I do want to point out the worst days have largely come since the end of October, and we really have happened over the last few weeks in terms of deaths. Continuing down to the lower left plot, you can see the new deaths reported as single bars per day. We had 15 yesterday, and the 7-day average of deaths in the orange bar. And you can see in the red circle that they're plateaued and possibly going down in Wisconsin. I would expect that because deaths lag cases in Wisconsin by about 5 weeks, that we're going to continue to see high death rates, even if the case rates go down, through at least the end of December and probably through the first week in January. We'll go to the upper right-hand side of the slide. You can see that we exceeded 4,000 deaths on Saturday. There continues to be a male predominance, which has been reported in other countries and throughout the US. People of color continue to be disproportionately impacted by COVID-19, but the difference between the population representation and the deaths from COVID-19 actually is closing for both Black and African American and Hispanic and Latinx populations. And that's largely because most of the new cases have been people that self-identify as white or Caucasian. And that's a trend that we've been tracking for the last 2 months as COVID-19 spread through the rural parts of our state. I can go to the next slide, please. This is just a picture of a few trends. Let me just start with the R number on the left. That's below 1 as of yesterday, 0.9 in Wisconsin, 0.94 in Milwaukee, relatively stable. The 7-day growth rate is improving at 0.8% in Wisconsin, 0.9% in Milwaukee. But remember, we've had so many cases that even a 1% 7-day growth rate means we're going to have a lot of new cases. So we need to see continuing improvement there. And the doubling times have stabilized. They're at 43 days in Wisconsin and 66 days in Milwaukee. And they were much better than this a month or two ago. And we would like to see those doubling times continue to extend out. The longer, the better. Because what the Wisconsin doubling time of 43 days means is that we're going to have 400,000 new cases 43 days from now if things don't change. And if you look at the bottom of the slide, I just wanted to show you trend data from RT.live that tracks the reproductive numbers in each state every day to compare where we are as opposed to our neighboring states. And you can see starting in March, we've had some hovering around and above 1.0 with being at or below 1.0 now, if you look on the right side of Wisconsin, for about a month. If you look at Illinois, they're tracking very similarly to what we've been tracking, and they have been since the beginning of the pandemic. And the same goes for Iowa on the right. If I showed you Minnesota's plot, it would look very much the same. And I think this is important because it highlights that the virus doesn't stop at county lines or state borders, that when we think about trying to control the pandemic, interstate and statewide collaboration is our best approach. Next slide, please. I want to talk about the hospital indicators here, starting at the top left. Over 19,000 patients have been hospitalized with COVID-19 since the beginning of the pandemic. that is stabilizing. And only 4.4% of the patients who've had a COVID-19 diagnosis have ended up in the hospital, and that's much improved since the beginning of the pandemic. Continue to track to the middle panel on the left. We have 1,425 inpatients with COVID-19. That's down 77 from 7 days ago. And you can see that we peaked at almost 2,300 on November 18th. And currently we have 318 patients in intensive care units with COVID-19, and that's down from a high of 456 on November 16th. Moving to the top right, we have 239 ICU beds available in Wisconsin, and that is improving. We were perilously close to only having 100 beds available about a month ago. We have been consuming personal protective equipment, and our trends are worsening, and the most critical needs are gowns, masks, and goggles, but supplies as of this moment are adequate. If you look at the middle right, I want to show you the trends for hospitalizations in Wisconsin. As you can see in the dark blue line, hospitalizations peaked about 4 to 5 weeks ago, and they've been trending downward, but still significantly exceed any of the surges that we had earlier in the pandemic. If you look at the light blue line, that tracks intensive care unit patients. Again, we peaked 4 to 5 weeks ago, trending downward, but not as significantly as the hospitalization trends. And then finally, a point I've made before, we have 1,845 available ventilators. I don't believe that ventilator availability will ever be a limiting factor for our ability to take care of patients with COVID or other patients that require ventilators without COVID at any time going forward. And next slide, please. Now, why is COVID-19 decelerating in Wisconsin? I hope that the data I showed you is fairly convincing and consistent that in fact the pandemic is decelerating, but we still have a high burden of disease. There are 3 potential reasons. One, and I'm sure this is part of the reason, is that people simply are being more diligent about protecting themselves, especially 4 to 5 weeks ago when people realized that our hospitals were full, our ICUs were at 95% occupancy, and many of our healthcare providers were out either with a COVID-19 infection or in quarantine. The second is really interesting. It's a hypothesis called the low-hanging fruit hypothesis. And the idea is that the most susceptible individuals have already gotten infected. And those would be people whose behaviors perhaps weren't as cautious as others, or higher risk groups like elderly individuals in congregate living situations like nursing homes. And there may in fact be some truth to this hypothesis. And then the third potential reason is another hypothesis called the network hypothesis. In other words, key people who sit at the nexus of different social networks may have been infected and either sequestered away in hospitals or quarantining so that they're not transmitting the disease then from one network to another. My guess is that all 3 of these have some potential influence on the deceleration of the pandemic. But what I would like everyone to understand is that the deceleration is simply not likely to be from herd immunity. We are not close to 70% of the population having been infected. We may be at 30% if you believe some of the upper boundary estimates, but that simply is not enough to confer herd immunity to our population. And I've had others say, well, we're testing fewer people. Maybe that's the reason why we're having fewer cases. Well, it is true that if we test fewer people, we'll have less cases, but that would not result in lower hospitalizations or death trends. We go to the next slide, please. Now, I just want to talk a little bit about vaccines. Dr. Schauer is going to talk more about them later. This slide here basically is a takeaway for you. We all know that one COVID-19 vaccine will be available this week and hopefully another next week. And the idea here is that the more people who receive the COVID-19 immunization, the more quickly we can achieve community protection. And if we get up to 70 to 75% of people who are vaccinated, we may have quote unquote herd immunity. We're going to need to wear masks though in the early phases, even if we've received the vaccines, to prevent transmission of the disease. And there are a lot of other reasons for that that I can go into detail about later if people have questions. So if I can go to the next slide, please. So the Pfizer vaccine received FDA emergency use authorization on November 11th, and there are several safe and effective COVID-19 vaccines in development. The Moderna vaccine is going to be reviewed on this Thursday, and hopefully will receive rapid approval as early as Friday. The initial doses are going to be limited to frontline healthcare providers and long-term care facility workers and occupants. And I just want to make sure everyone understands and puts into perspective the amount of vaccine we're going to have and the number of people we're going to need to vaccinate. We have 20,000 doctors in Wisconsin, 100,000 plus nurses. There are 10,000 residents and workers in nursing homes. We are only slated to receive about 50,000 doses from Pfizer and about 16,000 doses from Moderna, based on the latest information that I have. So we can either give one dose to 60-some thousand people, which doesn't cover all the healthcare providers or occupants of nursing homes, and hope that we get enough to give them the second dose. Or we can choose to vaccinate about 30 to 35,000 people. Clearly not enough to cover everyone in nursing homes and all healthcare providers. So I also want to point out, no single drug company is going to be able to meet the short-term demand for vaccines. We're going to need many hundreds of millions, possibly 1 billion doses in the United States. And I've listed the companies on the bottom that are most likely to have vaccines that will be available on the market by or during the first quarter of 2021. And I want to point out that the AstraZeneca Oxford vaccine is likely to be reasonably effective. It's inexpensive and easy to distribute, and it can be produced in mass quantities. That could be approved as early as January. We're hoping that the Johnson & Johnson vaccine also will apply for emergency use authorization in January or February. They do have one arm of their trial for a single shot vaccine rather than a 2-shot vaccine, which could be very promising. And even more interesting, Novavax, which is an American company, is very close to approval in Europe, and they have significant manufacturing capacity. It is possible that Novavax also might be on the market here as early as the first quarter of 2021. So lots of promising news about vaccines. Next slide, please. Will the vaccines be safe? Yes, they're going to be relatively safe, and the risk-benefit ratio is very, very positive in terms of getting the vaccine. The safety and effectiveness of both the Moderna and the Pfizer vaccines have been assessed and reviewed by scientists and governing bodies like the FDA. These vaccines underwent testing in trials with no serious adverse events reported that were attributable to the vaccines, which is quite remarkable. Although I do want to point out that the studies excluded children under 16 and had very few pregnant women. So right now, children under 16 and pregnant women are probably not going to be on the list of folks that receive the vaccine early on. I also want to make sure everyone's aware of subsequent cautions from the United Kingdom about 2 patients who developed severe allergic reactions or anaphylaxis after receiving the Pfizer vaccine. These 2 patients were carrying EpiPens, and they both had histories of strong allergic responses to food. So what I would say is testing of COVID-19 vaccines shows that they're effective, and they're effective in diverse ethnic groups, and this is particularly important when we think about people that are essential workers, people of color, and other disenfranchised minority groups. Every adult age group, including people over 65, also developed strong protection from these vaccines, as well as those with existing comorbidities. Again, however, there's not been comprehensive testing on pregnant women or children. And I want to make sure that everyone knows the 9 vaccine manufacturers likely to come to market in the US signed a pledge committing to maintain high ethical standards, sound scientific principles, and to make safety a top priority. And I believe that they will do so. Next slide, please. So what to expect? Obviously, I think most of you know that an intensive care unit nurse in New York City was the first in the US to receive the Pfizer vaccine shot this morning. Like all vaccines, they're typically given in the upper arm. Both the Pfizer and Moderna vaccines are given in 2 doses, 2 shots, 3 or 4 weeks apart, 3 weeks for Pfizer, 4 weeks for Moderna, are needed for best protection. And I want to make sure everyone knows the first shot gives you about a 50% protection in terms of reducing your risk of getting COVID-19. The second shot is really required to get that up to 95%. And like many vaccines, there will be an immune response and some local symptoms that include injection site tenderness, redness, and swelling, and some systemic symptoms such as fever, fatigue, nausea, headache, joint pain, and muscle aches. These are to be expected and should go away within 1 to 2 days. Immunity peaks 4 to 5 weeks after the second shot, but as I mentioned, there even is some immunity that starts within a week or 2 after the first shot. And one thing everyone needs to understand, until 70 to 75% of the population has been vaccinated, all of us need to minimize interactions outside our home and continue to practice the 3 W's: wear a mask, watch your distance, and wash your hands. Next slide, please. This is just an infographic, and I'll skip this because most of you already know what we need to do. Here, this slide is just a vaccine timeline. I provide it for your download and future reference, but you've heard that most of the outlines from me earlier in the talk. Next slide. As we go through the holidays, I wanted to provide some links to you for risk calculators. I particularly like the third from the bottom, which is a Georgia Tech risk calculator, because it allows you to actually focus in on your own zip code, program in your individual risk factors, and then the activities you might be doing to calculate a COVID-19 risk. I also want to thank the Wisconsin Medical Society for publishing a risk calculator as well, and that's second from the top. And next slide, please. These are simply the sources of data that we use, and with that, I'll turn it back over to David and Julia. Thank you.
Thank you, Dr. Raymond, for that very thorough and comprehensive report. You've done an outstanding job keeping us informed and aware. And just to repeat your 3 W's, the GMC backs you with the social distancing, wearing a mask, and washing hands. Our next speaker is Mayor Tom Barrett. So please join me in welcoming the mayor for some comments. Mayor Barrett.
Thank you very much, David. And like you, David, it is actually amazing to listen to the doctor talk, because Dr. Raymond does such a phenomenal job, I think, in educating all of us about this incredible pandemic. And I want to actually go back all the way to March, when we had our first meeting here in City Hall, and it was Dr. Raymond who came in and talked very, very soberly about this disease. And this was before we had even had a case in the city of Milwaukee, and how this was going to be a challenge for us throughout this nation, and certainly was going to be a challenge for us here. And since that moment, and the gravity that he brought to this, I think we have all benefited jointly from the work he's done. That meeting really led to a lot of the work that had been done here locally with the hospital systems, with the local healthcare systems, with the state of Wisconsin, and put us in a position where we were able to very, very quickly move on the site at State Fair Park, which I'm still very, very happy that we have there as our insurance policy. Was the beginning conversations for the UEOC that led us to then move with the testing with the National Guard. And I want to, again, thank Governor Evers and the National Guard. They have been phenomenal partners throughout all of this in helping us get the testing that is so necessary. And now, 9 months plus, as we begin to focus on the vaccinations, this will present some new challenges. And in real time, I think the most accurate word to describe what's going on is fluid, because the situation is so fluid. As Dr. Raymond said, if we get 50,000 dosages from Pfizer and another 16,000 from Moderna. That doesn't come close to covering the healthcare workers, much less the residents of the long-term care facilities and people with the comorbidities. And so right now, there's a lot of conversations going on with the state of Wisconsin, the Department of Health and Human Services, and the first category, which of course is the frontline workers, is the priority. The question is going to be the distribution chain, how that's going to be distributed through the different networks. And I have a particular concern, and this goes back to the very, very first time that we saw the locations of this disease in Milwaukee, where it was hitting the African-American community in Sherman Park and northeast of there very, very hard. Subsequently, it has gone very, very deeply into the Southside community here in Milwaukee, the Hispanic community. And as we've seen, at least up through now, as Dr. Raymond said, now the mortality rate differential is beginning to close, but we saw much higher mortality rates, particularly in the African-American population. We saw a lot of illnesses in the Hispanic population, but I think because of the relative age, we did not see the mortality rate. All this is a precursor to saying when we begin the vaccinations and the distribution of the vaccinations, there are going to be real equity concerns because the hospital systems are by and large located more heavily in the suburbs, and a lot of their workers are in the suburbs. And yet we've seen some very serious issues in the city with low income people, with people of color, with essential workers. As I've had my conversations with the state, I have raised quite pointedly the need to include the federal qualified health centers because they are the ones on the ground in the city of Milwaukee that have so much interaction, particularly in the neighborhoods where we have seen a lot of the problems. So I want to ensure that when we have the vaccinations, that we have not only the federal qualified health centers, but that we have the school nurses, that we have people that are working in the institutions, whether it's the jail or the house of detention, that those individuals have it. So this is all happening in real time. And I think we're all well aware that this is the most widespread distribution of vaccinations that we have seen since the polio vaccination in the 1950s. And it is remarkable that the FDA has acted as quickly as it has. It's remarkable that we have so many manufacturers that had stepped forward. But now the logistics of the distribution are going to come into full play. So I'm eager, like all of you, to hear from our panelists as to what their predictions are. But I think it's pretty accurate to say that right now we know who the first group is. We know who the 1A group is. We're not going to get to all of them, but then we're going to have some real serious conversations at the state level, at the local level, at the national level as to who comes next. So a lot of work has been done, but there's a lot more work to be done. So let's keep working together. Back to you, David.
Thank you, Mayor Barrett, for your leadership and deep concern on this serious matter. So to introduce our next speaker, we are joined by a special guest, attorney Michael Gaba. Michael is a shareholder and FDA practice vice president for the large national law firm Polsinelli. He was introduced to us by GMC member Tracy Klein, who is also a member of that firm. Michael has a 25-year history of representing clients before the FDA, including to navigate FDA pre-market regulatory pathways and to counsel companies on FDA post-market compliance matters. Please welcome Michael Gaba to introduce Dr. Norman Baylor. Michael.
Thank you, David and Julia, for the opportunity to introduce Dr. Baylor. When Tracy reached out inquiring about an expert on vaccines, Dr. Norman Baylor was at the top of my list. And when I finish my introduction, you all will understand why. Dr. Baylor is the president and CEO of Biologic Consulting, a full-service regulatory and product development consulting firm for biologics, pharmaceuticals, and medical devices. In his current role, Dr. Baylor focuses his strategic consulting in the areas of vaccines and vaccine-related products, while also supporting established multinational pharmaceutical, biotechnology, and medical device companies to academic and research institutions to small biotech and medical device startups with their FDA needs. Dr. Baylor's clients value his 20 years of experience with the FDA, most recently as the agency's director of the Office of Vaccines Research and Review. In his prior position at the FDA Center for Biologics Evaluation and Research, Dr. Baylor was responsible for planning, developing, and administering CBER's broad national and international programs and operational activities involving vaccines and related products. He has also served as the FDA's liaison to CDC's Advisory Committee on Immunization Practices and to the Department of Health and Human Services National Vaccine Advisory Committee. Dr. Baylor continues to serve as an expert advisor to the World Health Organization. Dr. Baylor, thank you for joining us today. We very much appreciate your participation.
Thank you, Mike, and I want to thank all the organizers and the Greater Milwaukee Committee for inviting me to make a presentation today. I'll just share my screen. So what I'm going to try to do in the time I have to speak is I'm going to really focus in on the business side, how the pandemic has impacted the business and how vaccines hopefully will get us out of this at some point soon. And then I'll also weave in some caveats about the vaccines as far as the approval process. So let me start out by saying we all are aware that of the severity of the COVID-19 outbreak. This has changed our lives. I mean, we know that we have unprecedented responses now from government bodies, from businesses. New laws and policies have been implemented. We have guidances across the country that have been implemented and across the globe, in fact. And then there are also many people from the business community are sending their employees home. Many people are working from home. I mean, we're having this meeting over Zoom, so our lives have really changed. And the one good thing out of this is we have the public health is now at the forefront of our awareness. I think the American people really understand or should have an understanding of how important public health is in fighting these type of pandemics when they arise. Next slide. And I just wanted to show this slide to reiterate what Dr. Raymond presented. I mean, this is over the weekend. And it's almost like a heat map. I mean, we are in critical condition. Things are slowly improving in some parts of the country, but then these really dark areas. I mean, and particularly, I'm in Maryland and the Virginia area on the East Coast. But when we look at some of these really dark spots in the middle of the country, and we didn't see these at the beginning of the pandemic, and now. Things are raging in this country, and we have to tackle this pandemic. And the next slide, please. And so what has been the impact on businesses? First of all, there's been industries have been negatively impacted as far as consumer demand. We've seen consumer demand for many products decline. We've seen our restaurant businesses really take a major hit. And so overall, this has left this country in critical shape. I mean, we've seen a number of people unemployed. We've seen poverty. More children are going without food under these conditions. I mean, it's really critical. And so many small businesses, they even lack the cash reserves to weather. And many, I mean, you can drive through any city in this country and see where really thriving businesses have gone out of business because they just could not weather this storm. And so there's also a possibility of a startup depression where we have new companies don't enter into the job market because of the pandemic. So we usually have a reiteration of new companies evolving, but this is not going to happen during this pandemic. And so the CDC has outlined, the Centers for Disease Control have outlined ways for businesses to adjust to the pandemic, such as reassessing their essential functions and reliance on others and communities have also relied on these services and products. And so it's been a tremendous impact on businesses as well as the communities at large. Next slide, please. And so we have vaccines. I mean, and this is the good news. And this is an amazing feat. I mean, I've been in vaccines most of my career. And we have never developed a vaccine from discovery to actually authorization to use in less than a year's time. It's been 11 months, and this vaccine has gone from the sequence of the virus to a vaccine to several vaccines. In fact, there are hundreds of vaccines that are in development. So that's the great news. I mean, it's really unbelievable. The other fastest vaccine, the fastest vaccine prior to the COVID vaccines was the mumps vaccine, and that took 4 years to develop. So effective vaccines against COVID-19 are key in controlling the pandemic and resuming travel and economic activities. So it can't come soon enough. The progress on the vaccine rollout offers a prospect of a return to an economic normality. And a vaccine will protect frontline workers who may be in line to receive the vaccine after our healthcare workers based on the CDC's phase 1 priority. And then also the long-term care facility residents, they will be in the phase 1 as well. So employers must determine how many of their employees would receive a vaccine and how can they support employees in receiving the vaccine. So as been stated earlier, there are a very limited number of doses of vaccine available now. But now is the time for businesses to think about when the vaccines are come in the next tier, how will these vaccines be distributed? What will I request of my employees? So many companies have sought to require vaccination of their employees, and in order to ensure safe work environment. And I caution employees and companies of requiring the vaccination. You have to think about the impact. There's the companies are really going to have to work closely with their human resource departments to make sure that we're not violating any rights of the individuals. We want to make sure that people are confident in the vaccines. And so mandating a vaccine, that's an issue that is, I would advise companies to tread lightly. But then there are some occupations, for instance, hospitals and healthcare facilities, where it's imperative that the employees are immunized once vaccine becomes available. The next slide. So does the vaccine mean that we can do away with masks and distancing? I think you heard clearly from Dr. Raymond that no, this is not the case. Vaccines, of course, start rolling out today, but supplies are extremely limited. There are approximately 40 million doses that will be distributed between now and the end of 2020. And that's probably between the two companies, Pfizer and Moderna. Production has been slower than they expected, and so the rollout will be a little slower. We need in the United States we need about 600 million doses. These vaccines, the vaccines that are ahead are 2-dose vaccines. The Pfizer vaccine is 21 days apart between the doses. The Moderna vaccine is 28 days between the doses. So we need 600 million doses in this country. So some populations have not been studied. So that's going to come later. And those studies are starting now. Pregnant women, children, the immunocompromised, this population will not be immediately vaccinated. And so when the community spread has stopped, that's the time that we believe that we can allow closer contact. And that's going to take, as been stated, about 70–75% to really get that level up where we can have so-called herd immunity. So in the interim, we need to continue to follow the guidelines to decrease the risk of the spread, mask, distancing, limiting employee density, limiting travel, and improving ventilation barriers and procedures that limit close contact. We're going to have to do that for a while. So with the vaccines coming on board today, we won't, normal will not come tomorrow. Normal will not come this winter. Normal will come later in the probably next year when we have immunized a larger population in the vaccine. I do want to emphasize at this point about the vaccines, the caveat for the vaccines. The Food and Drug Administration authorized these vaccines for emergency use. These vaccines are still experimental. They are not licensed or approved. And so FDA grants this authorization based on the data that they've reviewed up to this point. There's about a 3-month median time of safety data for these vaccines. The efficacies were quite clear across various populations in both the vaccines, the Moderna and the Pfizer vaccine, 95% efficacious. So we're going to have to remember that. I mean, many of us will be immunized once these products are licensed, and that'll probably be later in the fall of next year. But these vaccines right now under emergency use authorization, the benefit outweighs the risk. That's why these vaccines have been authorized by the Food and Drug Administration. If I could have the next slide, please. And so will a vaccine allow a return to normal working conditions? So if vaccines continue to demonstrate safety, high safety and efficacy, and this is why I gave the caveat about our safety data are limited at this time. It may be in time result in social distancing and other measures being relaxed once we have that high herd immunity. But given the way we had to adapt to living with COVID-19 in 2020, it's possible that our working conditions may never return to how they were pre-pandemic. We need to think about that because many employers have discovered the benefit of remote working that previously may have thought impossible, such as Zoom and all of these virtual ways to work. And so this has resulted in a culture shift. The question I ask at my company is, will I get my employees back to work? They're all working virtually. It's working fine. So the challenge will be, why should I come back in the office? We're working fine. So I think employers are really going to have to think about this. And also from an economic point of view, the cost savings in having people working virtually. So it's something that needs to be thought about. And if I could have the next slide. So again, let's see. Yeah, I've covered this. Next slide. Yes, here we go. So businesses should have a realistic expectations. Businesses should expect to return to normal probably, possibly by the end of 2021. The verdict is still pending on the duration of protection of the vaccines. We don't know how long protection will last. As I said, the data are very limited. We have about 3-4 months of data on the efficacy. So we need to continue. And these vaccines, the FDA has required that these vaccines are studied out to 2 years. And so we'll have much more information as these studies are completed, how long the duration of protection is. And businesses seeking to bring back workers to the workplace, even after the vaccine are widely available, we need to think about, is it essential to bring those individuals back and when? Is it safe to bring your employees back? And is it mutually agreed? This is something that needs to be discussed with the employees. And if I could have the next slide. So I would encourage businesses to have a continuity plan. I've been working on the pandemic influenza plan. I worked on that with the Department of Health and Human Services when I was at FDA. And every business, just like every organization, should have a business continuity plan. But this continuity plan is based on emergency events caused by infectious diseases. So this document would focus on creating a business plan. How will we operate if there's an emergency? I think had many businesses had a type of business continuity plan based on infectious diseases, they may have been able to respond to the pandemic much better. And also even on the government, local, state, and federal governments, if we had really implemented the pandemic plan in advance of the pandemic. We knew and we know for years that a pandemic is coming. We still know that we will have an influenza pandemic. Influenza pandemics are cyclical. So we know we are due another influenza pandemic. And so this is the time, if the businesses don't have a continuity plan, to start thinking about it. How will I operate if there's an infectious disease outbreak? And I believe that's my last slide. Next slide. So I want to thank the organizers, thank everyone for listening. And I guess at the end of all the talks, I'll be glad to take your questions. Thank you so much.
Thank you, Dr. Baylor. Thank you for that very informed view. And thank you also for your time today in participating. Our next speaker is Dr. Stephanie Schauer. She is with the Wisconsin Department of Health Services. She's the immunization director. She and her team have been at the forefront for distribution of the vaccine in our state, writing the official COVID-19 vaccination plan for Wisconsin. Welcome, Dr. Schauer. We look forward to your remarks.
Great. Thank you so much, and I really appreciate the invitation. Next slide, please. So I think it's important, you know, vaccine is part of our response plan. It's part, but it's not the entire plan. We have, as many of the speakers have talked about, continuing to use the things like washing hands and watching distance and social distancing. Those things still need to continue, but we're so glad to be able to add in vaccine as being part of our response plan. In terms of the objectives, it is to establish an infrastructure that is ready to receive and distribute vaccine to populations throughout Wisconsin. It's educating and enrolling vaccine providers to promote confidence in the product and the process. It's providing technical support and guidance for effective vaccine planning and implementation to providers as well as health departments. And it's educating and encouraging people in Wisconsin to get vaccinated when the vaccine becomes available to them. I think the developments of late related to vaccine really offer great hope, but we do need to consider them in the context of the broader situation. As you've heard, there is going to be a limited initial supply, and it's critical to continue that diligence for the masking and the distancing, as I mentioned. But it is also important that we need to emphasize that this will be swift but a safe distribution of vaccine. So the state does have a solid plan in place for swiftly and safely administering vaccine, but it's important to remember that a successful vaccination process really involves all of us committing to the progress and encouraging people to get vaccinated. So we are prepared to go ahead and receive and distribute the two vaccines, the Pfizer, as you have heard. And the one thing I will say is with this business, you know, slides that are more than several hours old are just that out, are sort of seem to go out of date. We do expect to receive 49,000 doses of vaccine, and they are starting to enter the state today and will continue through this week. These will be sent to hubs that can attend to the ultra cold storage requirement. The Pfizer vaccine really has a number of challenges in front of it, including the number of doses that are in a particular allocation, 975 doses, and then it has this storage requirement where it needs to be stored at -80. So we are having hubs that can take on that piece, and then working with them and linking them up with smaller spokes who don't maybe have that capacity, and taking care of that vaccine so that we can get it to the spokes and they receive it on a pro rata basis, and they don't need to store it at -80, and they can get doses in less than increments of 975. This vaccine to start with is really going to be intended for those frontline healthcare providers, and we'll talk a little bit more about that. And the state will be providing transportation and vaccination support in this hub and spoke model. On the other hand, the Moderna vaccine, we expect 100,000 doses to arrive the week of 12/21. This is pending the EUA approval. So just to be very clear, the Pfizer has cleared all of those hurdles and has the EUA in place, whereas the Moderna, they are set to go ahead and discuss that on the 17th, so later this week. This one, because of what it comes in allocations of 100 doses, and the storage and handling is much more akin to what we're used to vaccines. And so this one can actually be shipped directly to vaccinators, and most clinics who vaccinate are certainly able to handle those types of requirements. This vaccine will be intended for probably skilled nursing facilities as well as healthcare providers. And once again, we will continue to provide technical assistance. Next slide, please. So, you know, the program, it does involve phases and it requires patience. The amount of vaccine that we have initially allocated is small in comparison to the groups that are initially recommended. In phase 1A, critical healthcare workers and long-term care staff and residents are amongst the first, and that's in phase 1A. And I will say that we have about over 400,000 healthcare workers alone. And so you can see when we're talking about our first allocation being 49,000, it's going to take some time. Once we move through those groups, we will be moving into phase 1B where we go towards essential workers. And there's lots of conversation about who is in that group. The State Disaster Medical Advisory Committee is wrestling with that on behalf of the state and will make recommendations to DHS. And so those conversations are ongoing and folks can go ahead and listen in and provide public comment. As it says here in green, this is going to be tightly controlled administration occurring in closed settings that are best suited to ensure that we're reaching the critical populations that we're looking for. Phase 1C is anticipated to be individuals over 65 and those with underlying health conditions. And as we move towards phases 2 and 3, vaccine becomes more readily available, and we start administering in settings that we're used to seeing, for example, with influenza, in your healthcare, maybe from your healthcare provider, in commercial settings, and from public health, so pharmacies and the like. And that's where in phase 2, we're really getting the remainder of those phase 1 populations and moving into general population, and the same thing with phase 3. Next slide, please. So as I mentioned earlier, it really is critical to understand the nuances of these vaccines. As we've heard earlier, the Pfizer is 2 doses separated by 21 days, and it is approved for use, or I should say authorized for use in individuals 16 years and up. And that the clinical recommendations, we saw actually the MMWR was just published yesterday, I believe, and so that clinical guidance is out there. I will say with respect to the 16-year-old, it really is going to be those 16-year-olds who are in the phase 1A. So probably we're not looking towards large vaccination of individuals 16, 17, 18, but really those who are working in healthcare settings, long-term care settings. That's where that will be. In terms of the Moderna vaccine, it also is a 2-dose series separated by 28 days. And we do anticipate that the initial application will be for adults only. But as we've heard that as more data comes in, that the EUA may be increased or approved for additional age groups or recommendations. And once again, on the 17th, we expect that we will get that information should it prove to be approved or authorized by the FDA. Next slide, please. So the populations that will be prioritized. So the phase 1A eligible critical healthcare workers are individuals who provide direct patient service, either compensated and uncompensated, engage in healthcare services that place them into contact with patients who are able to transmit COVID-19 and or those who are in contact with infectious material containing COVID-19. In addition, phase 1A includes residents of long-term care facilities. So this is defined as adults who reside in facilities that provide a variety of services, including medical and personal care, to persons who are unable to live independently. And skilled nursing facilities will be prioritized, and then we will move to the other types of facilities as after that. Next slide, please. The critical work now is registering providers. Any entity that wishes to provide COVID-19 vaccine must complete the registration process through DHS. This is a federal approval process or federal form that needs to be filled out and verified. It includes training to use the Wisconsin Immunization Registry, which will be a key part or is going to be a key part of the whole campaign, as well as vaccine storage and handling, and ensuring that all providers have what they need to ensure a safe and effective vaccination campaign. This is a rolling registration, and we will continue to enroll folks, particularly those who are going to be serving phases 2 and 3. We will keep the registration process open. We recognize that this has been a challenge. As I said, it is a sort of a 7-page form, and there's lots of checks in there, but we are moving as quickly as we can to get vaccinators through. And as the vaccine increases, we will also see the number of vaccinators increase. And so we will see a gradual increase on both sides. Next slide, please. Building confidence is critical. I can't emphasize this enough for stopping the spread. We're going to be working with local ambassadors to build confidence and really assuage concerns about the vaccine. It's important if people have questions that they get them answered and that they can be reassured that the process that has been used thus far through the FDA and through the ACIP has been a transparent process, and that no corners were cut, and that we are here today with a safe and effective vaccine. Can't reiterate enough that it's important. Oh, Les, please go back one more. That it's important for everyone to continue masking and distancing, just as we've talked about, and that community organizations, and sort of the last bullet is really emphasizing community organizations have an important role to play in this work. We at government can't do this by ourselves. The word needs to be carried by you, partners, about the importance of vaccination, about the safety of the vaccination. So with that, I will go ahead and end there.
Thank you, Dr. Schauer, for leading the effort on behalf of the state to put together an effective and safe plan. We know you and your team are working through urgent and unique circumstances. So our final presenter today is Dr. Tito Izzard of Milwaukee Health Services, a federally qualified health center. Health disparities have long existed within communities of color, and unfortunately, that is no different with COVID. Dr. Izzard will share the perspective of a community health center that has experienced these disparities. He will also touch on how to gain trust within communities to ensure that vaccinations are received effectively by community members. Doctor, let me turn it over to you.
And thanks to the GMC. Can everybody see my slide there?
Yes.
Okay, great. Well, I know we need to try to catch up and save time to make sure the audience has time to ask questions. So I'll go through it pretty quickly, but welcome any further questions that we may have. So one of the things I want to take is a different perspective, looking at COVID-19 and this conversation regarding health disparities. There's been a lot of discussion nationally and locally regarding this issue, and wanted to bring the conversation regarding why the social determinants of health are really not the only answer that we should be participating in this conversation. When you look at, for particular ethnic minority groups, and each group actually may be unique and different as far as why they experience different health disparities, but for the African American population, which my federally qualified health center on the north side of Milwaukee, which serves about 85% African Americans, with 97% of our patients living under 200% of the federal poverty level, that we actually see that as the economic components that significantly influence the health disparity more than just what we would call social determinants. So if you look at just those top four regarding income, education, employment, and housing, historically when the social determinants were developed and discussed, wealth really wasn't discussed in the conversation. Really was more income. But I think most of us have recognized over the last decade or so, especially in the latter portion of the decade, the significant impact of the lack of wealth or the lack of economic inclusion has had on all of these variables, including overall health. I like to use this very simple definition to say, well, if health is stable living exhibited within the body, the mind, body, and the spirit, if that's true, then for Native Blacks, health disparities are a direct consequence of being an American descendant of slavery. And it really, it moves beyond just a poverty issue. So just making sure that we all have a relatively straightforward definition of health disparities. You can see here that I'm actually referring to health disparities result when vulnerable population groups experience the dual combination of inequitable resource distribution and care delivery, which are required to accomplish and sustain health parity, in addition to unequal access, coverage, and representation within the healthcare system. So for American descendants of slavery, then life actually is a continual health crisis. And this is what 3/5 citizenship health status actually would look like here in Milwaukee and across our country. And how does that impact and play a role in COVID-19? Well, what we've seen is even for other ethnic groups such as the Native American population, we see that through the Indian Health Service, they have been terribly underfunded since its inception, where Indians are not, or Native Americans are not getting the equal protection under the law. So for example, where Medicare funds about $12,000 per beneficiary per year, the IHS receives about $5,000 per person. So in this respect, this is actually less than what the VA, Medicaid, and the Bureau of Prisons receive, which is a conflict or contradicts the original treaties that were produced to make sure that Native Americans had adequate health care. So when we look at SARS-CoV-2 or COVID-19 on American descendants of slavery, as well as the ethnic minority vulnerable populations, this kind of just lists some of the categories to show how complex of an issue it is, so that we don't oversimplify our explanation or understanding of why the health disparities exist as it relates to COVID-19. And it helps us understand why vaccinations of the community is going to be extremely difficult. So when you look at, we know from all these great presenters earlier, the disparate data that was seen between the vulnerable populations. We know that for ethnic minority populations, they tend to live multi-generationally, whereas 69% of the Latino community actually lives in multi-generational living compared to the white community. And then when you look at inadequate, thus far that we've experienced here in Wisconsin and in Milwaukee, the inadequate public health response, whereas we should have seen a FEMA-like response initially in the neighborhoods, just like if there was a fire or flood, where the next day there would be water and other resources for the community. We failed to create a COVID-19 distribution center to be able to make sure that people had access to masks, hand sanitizer, disinfectant agents, and all of those things. And so, and there's a lot of reasons that led to that, but all of these things end up being what the community ends up living with. And now it starts to impact on how people feel about government and how they actually feel about vaccinations. So Dr. Jones, an epidemiologist, talked about how we've mapped the human genome completely and there is no basis in the human genome for racial subspeciation. But despite that, we still see that for African Americans, if they, as a group, persistently have the worst health status of all the ethnic minority groups, disparity gap exists within all socioeconomic groups, and it goes beyond just lifestyle choices that people make. And so the most common variable is the ethnocultural lineage to American slavery. So I use this as one example to let the audience know that it's not just about poverty, and where we see for the American descendant slavery population, that when you look at African Americans, when income improves from 100% or below the federal poverty level up to 400% of the federal poverty level, the prevalence of cancer actually worsened by 43%, whereas it improved for the white community. So this is just one example of how, if we try to think narrowly and think that it's just a poverty-driven issue when it comes to health disparities for African Americans, we're being limited in our thought process and in our science. So there are a few things that are more important than to not harm innocent people. And unfortunately, the Hippocratic Oath, do no harm, standard has not always been upheld when applied to American descendants of slavery and other economically vulnerable communities. And even Milton Friedman, the conservative economist, stated that the role of government is to ensure fairness in transactions and interactions between person A and person B do not harm person C. But unfortunately, we haven't seen that play out historically. And even what I did is I took a look back, going back to Reconstruction, and looked at all of the elections post Reconstruction, and 39 times one party, whether it was Republican or Democratic Party, controlled the governance. And so out of that 39 times, 29 of the 39 times, or 75% of those times, Black Americans voted with the winning team. But despite that, yet racist and social economic status, class-based politics over economically inclusive policies have prevailed. So what do we do? How do we go about addressing this? So one of the things that we have to do as a collective community is think in terms of restoring the Black institutions. So why haven't African Americans used their leverage? Well, the answer is because as a group, they've been broken due to the denial of their birthright, which is reparations, a comprehensive reparations plan to restore these 5 institutions. The erosion of the collective impact within the 5 Black institutions have occurred since 1965. And the loss of influence created a vacuum or void of leadership experienced in the Black community and society at large. And those 5 Black institutions, the Black family, the Black church, Black schools, Black media, and Black businesses. So what this country needs to do is to bring balance to the people, and thinking in terms of how public health being a collaboration between families, community advocates, healthcare, local government, state government, as we all work on the distribution of those federal resources back to the community. And if public health really working in this collaboration can actually bring some restoration of this balance between equality and equity. Well, what ends up happening though in the communities, when you think of the 5 states that all people experience, that's your physical state or physiological state, there's your emotional, behavioral, psychological state, there is your economic or financial state, there is your social or societal state, and then there's your spiritual state. And all of those states for every person works in balance. And it is that the wealth position of that individual and family that stabilizes these states and results in this homeostatic resiliency. But what happens is when a person has less resiliency or less opportunities to be stable, as we talk about, being stability, health being about stability, when there is that lack of stability, the instability creates dissociative behaviors, meaning that people will make decisions that are completely inconsistent with their faith, their values, their characters, and the belief system. So as one of the things that we want to do working together is to ensure that we're working with individuals who will help families, and stronger families build stronger communities, and in turn, the cyclical nature where a community helps more individuals, and we're able to address all of these areas. So the role of the public health in conquering COVID-19, one pandemic, one community, means that we will work together to ensure early detection, people are able to remain physically separated, contact tracing occurs, resource distribution of COVID-19 resources and other resources that help keep people safe and stable, as we're ensuring that people have immediate access for care, continuity of care. And just briefly, what was actually interesting, this survey in Massachusetts conducted between November 18th to the 25th, where 1,180 residents in partnership with Massachusetts League of Community Health Centers did the survey, And as we've all heard, that there's a lot of resistance to the vaccine, in particular with ethnic minority groups. But looking at those questions where do not trust the government on healthcare issues, how there's such a high percentage of ethnic minority groups. And in this case, even looking at the column of Republicans, you find very interesting bedfellows as it relates to some of the thought process. And down below where you said, do not trust the vaccines, 43% of Blacks and 47% of Latinos didn't trust the vaccine. And even thinking where you say, do not believe COVID is real, where if you have almost a third of Blacks really feel that the virus isn't real, even though we've seen it impacted and affecting our community, it makes us, we have to be aware of how instability creates dissociative behaviors, and that in the end, you cannot just convince people with education and information. You actually have to build relationships. So patient and community engagement is so critical, because when each of us have our own lived experience, and if we're only looking at it from what I call it, our side of the moon, but how are people's lives on the other half of the moon, on the light side versus the dark side? What perspective are we looking at? So in order to overcome these obstacles, we have to remember every patient is an individual. We have to ask, who are we actually listening to? And what are the barriers that may be preventing us from accomplishing our goals together? And thinking in terms of, Aristotle with the logos, ethos, pathos, and mythos, well, thinking beyond just giving people information, you also have to make sure that you have that level of credibility as a healthcare provider, as a community. And then the pathos is that emotional appeal. What are the emotional or fear factors that may be influencing the way people think? And then the overall cultural beliefs that need to be in the consideration. And so in the end, if health to us means stability between the mind, body, and spirit, then we need a restorative health equity plan that involves us all. So thank you, and be happy to answer questions.
Thank you, Dr. Azard. And I'd like to take this opportunity to also thank the other speakers, Dr. Schauer, Dr. Baylor, Dr. Raymond, and Mayor Barrett for this deep and informative amount of information. For those of you who have questions, again, please submit them to Q&A. I have one here, which I'll pose to the group. How will the cost of the vaccine be covered? Is it paid for by the government, by your insurance, or by the individual? And if it is insurance, how will that be handled for those who are non-insured or underinsured? So that's an open question for any of the speakers, if anyone knows the answer.
Yeah, well, I think for right now, I guess I'll just jump in. There are still a lot of unanswered questions. Most of us at this point are working off the assumption that the vaccines, whichever company, that the vaccine will essentially be free for the recipient, okay? Now on the back end, whether that means that there is some transaction that happens between the person's insurance company and the vaccine company, but for the most part, just like testing, there has, in most cases, haven't been an out-of-pocket expense. We are anticipating that there won't be an out-of-pocket expense for people to receive the vaccine.
That's my assumption as well, that residents and citizens won't have to be paying for this, or will be paying for it through their taxes.
Okay, thank you. And here's another question. Is there a need for increased testing and increased testing capacity? And is there a way to get quicker lab results, and would that encourage more people to get tested? That's also an open question for any of the speakers.
Let me jump in real quickly on the testing capacity. What we're seeing in Miller Park is a perfect example. We've actually seen the numbers dropping at Miller Park. We were probably over 2,000 when we first opened it up. I know on Saturday, I think the number was about 600, between 600 and 700. So we have the capacity. We have the capacity at the Northwest Side Health Center in the city of Milwaukee and the South Side Health Center. We also have capacity on the South Shore at the in South Milwaukee, and many clinics and providers provided as well. Their turnaround is relatively fast as well, but I'll let the healthcare providers. But there is a lot of testing capacity that is out there right now.
Maybe I could add to what Mayor Barrett said. Testing is only as good as your supply chain and your turnaround time. And I think right now in the pandemic, people, despite the fact that we can get it turned around quickly at Miller Park, are worried about the turnaround time and their wait time. As we get the pandemic more under control, I actually think that testing becomes even more important, because then you actually don't overwhelm your public health infrastructure, and you can do contact tracing and quarantining much more effectively. So we should at least maintain the amount we have now, if not increase it, and do everything we can to improve that turnaround time.
Yeah, and I would just say highly effective, efficient testing to be able to make sure that people can get results with as close to immediate results is important. One thing that's not discussed and hasn't even been discussed here today, and to make sure that the community understands that with the current vaccines, that the science has not proven that a person who is properly vaccinated, that person, it doesn't necessarily mean that person cannot become infected with the virus. The question is just reduces the overall symptoms. And it's not certain yet that person won't be able to, if they come exposure and infected with the virus, that they won't be able to spread it to someone else. So testing will definitely be a critical component in our community until there's a herd immunity. And as long as the COVID-19 virus is present in our community, then we should definitely think of utilizing testing in an efficient and effective manner to reduce still that spread to your loved ones.
Okay, and then one final question. The priority listing for who receives the vaccine is, I mean, it's set, and it's a good first step. You know, but as you get deeper into it, I'm sure that there will be lots of governmental debate and healthcare debate. But this question goes to, what is the plan, or is there a plan for vaccinating incarcerated individuals?
Oh,
So I don't know if there's been any discussion about that.
I can start. I can start. And again, the plan from the federal government, remember, these are recommendations from the Center for Disease Control Advisory Committee. The plans are left up to the states. The Department of Health and Human Services said they would allow the states to look at those plans, look at those priority lists, and adopt what the individual states need. So it will be up to the states to decide where do those individuals who are incarcerated fit in the plan. And the states also have the ability to shift around the priorities if they feel that that's necessary for their particular state.
Well, thank you. Okay, well, that concludes today's meeting. Again, thank you, speakers. This was very informative. We appreciate your time and the sharing of knowledge. The next meeting for the GMC membership is January 11th, and it again will be a Zoom call. So everyone have a good day and a good week, and the meeting is now adjourned.
Thank you.
Thank you.
Thank you.
Be with you.
Thank you.